Assalamualaikum. This is Masuna. Our group topic is hematopoietic stem cell transplantation, and my topic is allogeneic hematopoietic stem cell transplantation. First of all, the term allogenic means donating tissues which are genetically dissimilar, because of which immunologically incompatible. Allogeneic hematopoietic stem cell transplantation involves the transplantation of hematopoietic stem cells obtained from donors, bone marrow, peripheral blood, progenitor cells, or umbilical cord blood to a patient. Patients who are eligible to this transplantation includes the ones who have haploidentical donors. These includes parent, sibling, child of the parent with only one identical HLA haplotype, human leukocyte antigen haplotype. The haploidentical donors recently associated with graft failure and graft versus host disease, but now with improved regimen and modifications, we can use haploidentical donors. The second most important criteria is the patient should have normal renal, hepatic, pulmonary, and cardiac functions, and patient should not above the age of 65 years. This is the procedure of allogeneic stem cell transplantation. First of all, we collect the donor cell from bone marrow or peripheral blood, progenitor cell, or from an umbilical cord. Then we process the sample and remove the stem cells and remove emboli from the sample. Then we treat the patient with prophylaxis treatment and certain chemotherapy with or without radiation to kill the remaining cancer cells and to weaken the immune system, so the body prevent the rejection of donated cells. Then we infuse the blood to the recipient. Uh, for for understanding, we uh, use this case study, uh, understanding different aspects of allogenic hematopoietic stem cell transplantation. First of all, indications. The case study given here is a young patient of 22-year-old has AML in first remission after induction chemotherapy with standard doses of cytarabine and daunorubicin and consolidation with high dose cytarabine. He has poor risk cytogenetics and HLA typing performed on a family member has identified a fully HLA matched sibling donor. So all organ functions are normal, and the question is an allogenic HCT indicated for BS? So first of all, BS has AML, and AML is the most common indication of hematopoietic cell transplantation. Secondly, he has a matching sibling because HLA typing is fully matched, so he is eligible for allogenic HCT because of his poor cytogenetics and availability of the compatible donor, and also he is young and all organ function properly, so allogenic HCT is indicated for BS. Second, histocompatibility. Question is, how does histocompatibility influence the risk for graft rejection and graft versus host reaction in patients like BS who undergo an allogenic HCT? So, because the tissue transplanted in allogenic HCT is immunologically active, so there is a potential for bidirectional graft reaction. Two scenarios are there. First is that the cytotoxic T cells and NK cells of host, mean recipient or the patient, recognize MHC antigen of the graft, means donor, and elicit a rejection response. This is called as host versus graft disease, and for allogenic HCT it is called as graft rejection. And the result is that ineffective hematopoiesis. Second scenario is that immunologically active cells in graft, means donor, recognize the host MHC antigen and elicit response. It is called as graft versus host disease and abbreviated as GVHD. And so the essential step is taken for patients eligible for HCTs, finding an HLA compatible graft with an acceptable risk of rejection and GVHD. And for immunosuppression, we also use different regimens as a prophylaxis treatment uh, between mismatched donor and recipient. Uh, Secondly, we have harvesting, preparing, and transplanting allogenic hematopoietic stem cells. So, in this, we have question that hematopoietic stem cell from BS histocompatible sibling, prepare them for transplant methods and advantages of these methods. So between in allogenic HCT, the common problem arises ABO incompatibility. ABO incompatibility is increases the complexity, but it is not an obstacle. So we require additional processing if the patient is ABO incompatible, which occurs in 30 to 40% of sibling donors and higher in unrelated donors. So we manage it by removing RBC from the HCT product and transfusing type O RBCs. So the first method is bone marrow transplantation. Of bone marrow is obtained from donor under local or general anesthesia on day 0 of bone marrow transplantation. Multiple aspirations are obtained until a sufficient volume with a sufficient number of hematopoietic stem cells is collected. Then we process and remove bone marrow emboli from that and immediately infuse intravenously into the patient. It is the primary source for allogenic transplant in children. Second method is peripheral blood progenitor cells. Uh, Marrow stem cells continuously detach and enter the circulation and return to the marrow. So the peripheral blood is a convenient source of hematopoietic stem cells. The number of peripheral blood progenitor cells is estimated by using the cell surface molecule CD34 as a surrogate marker. The number of CD34 increase by mobilizing them from the marrow, and the agent we use for this purpose is filgrastim, 10 to 16 microgram per kg per day subcutaneously, followed by leukapheresis on the 4th or 5th day when peripheral blood level of CD34 plus is at its peak. Stem cell is usually obtained with one or two leukapheresis, with the optimal number of CD34 collected being 5 to 8 into 10 to raise to the power 6 cells per kg of the recipient body weight. Higher cell doses have been associated with not only more rapid engraftment but also fewer fungal infections and improved overall survival. It is processed same as bone marrow derived stem cells and induced immediately or frozen for future. Um, its advantages include it leads to the quicker recovery and with quicker neutrophil and platelets engraftment, and has lower relapse rate and increased disease-free survival. The donor may experience musculoskeletal pain, headache, mild increase in hepatic enzyme. The third method we have is umbilical cord blood. Uh, the blood from umbilical cord and placenta is rich in hematopoietic stem cells but limited in volume. So and in patient who have not acceptable matched related or unrelated donor, so it is an alternative technique for them. uh, Cord cells are obtained in delivery room after birth and delivery of the placenta. Cord blood then processed and samples sent for the HLA typing and frozen for the future. It At least 2,000 SCTs with cord blood donor have been performed, with more than 70,000 cord blood unit banked for the future HCT. Its advantages include it has several advantages over peripheral blood progenitor cell and bone marrow, because it is readily available, leads to the more rapid time to HCT and ability to tolerate greater degree of HLA disparity. Uh, it is it is designed to eradicate. Oh, sorry. Disadvantages include the limited number and quality of hematopoietic stem cells in cord blood. So, for BS, we recommend peripheral blood progenitor cell method, because he has matched sibling, and uh, also he is young. So this procedure is reasonable for BS. Uh, then we have preparative regimen for allogenic hematopoietic stem cell transplantation. In this, we have two type of regimens: myeloablative preparative regimen and reduced intensity or non-myeloablative preparative regimen. So the question in the firstly we have is, what is the rationale for using myeloablative preparative regimen for patients like BS who receive an allogenic HCT? Whatever regimens are used and what is recommended to BS? So this regimen is designed to eradicate immunologically active host tissues and to prevent and minimize host versus graft reaction. And basically, the preparative regimen is a combination of chemotherapy or radiation used in allogenic HCT. It is not for patient with poor immune system, because it is basically suppress the immune system, and also it is not for patients undergoing syngeneic transplantation, because they are identical twins, they have same HLA typing. So for BS, we recommend a regimen cyclophosphamide and total body irradiation preparative regimen is preferred because he has AML in his first remission. So this combination is one of the first preparative regimen and is still used today widely. Total body irradiation is myeloablative and immunosuppressive. It does not have cross resistance to chemotherapy and also reaches sites that are not affected by the chemotherapy, like central nervous system. Uh, Secondly, we have reduced intensity or non-myeloablative preparative regimen. Uh, the question here we have is describe the rationale for non-myeloablative preparative regimen in B as a candidate for such a regimen. This regimen is basically for the patients who are above 50 years. Uh, it is an improve. It is made for old age people with an improved understanding of graft versus tumor effect led to the development of a strongly immunosuppressive but not myeloablative preparative regimen. More than 60% of the patients receiving reduced intensity preparative regimen are older than 50 years. So BS is a young individual, so we are not giving him uh, non-myeloablative preparative regimen uh, because reduced intensity HCT is not indicated as first line therapy or any for any malignant and non-malignant condition. It is not an option for BS. Post transplantation immunosuppressive therapy. The question here we have what is the rationale for immunosuppressive therapy after an allogenic HCT? What is recommended for BS? So after infusion of the hematopoietic stem cells, immunosuppressive therapy is administered to prevent or minimize graft versus host disease. And this therapy is not for two types of the patients. Number one is syngeneic transplants because they are identical twins, so there is no graft versus host disease. And the other patients with a T cell depleted histocompatible allogenic transplant because in T cell depleted transplantation, volume of donor T cell infused into the patient is usually insufficient to elicit significant graft versus host reaction. Immunosuppressive therapy is slowly tapered and discontinued over 6 months to 1 year because of immunologic tolerance. Commonly used regimen for myeloablative HCT includes cyclosporine or tacrolimus, administered with short course of low dose of methotrexate. We can also administer corticosteroids. BS should receive cyclosporine and tacrolimus administered with a short course of methotrexate for post-transplantation immunotherapy. The regimen will lower the risk of graft versus host disease after his allogenic HCT with a myeloablative preparative regimen. So, here I conclude my topic. Uh, these are the different regimen, preparative regimen and post grafting immunosuppression regimens. Thank you.